to ask question at the end of the talk, and we can chat with the speakers. So the first speaker is Professor Vieira. I don't know how to pronounce it. I'm really sorry, Professor. Just please be quick because we are running out of time, but feel free to say everything you need to say.
Okay.
Thank you.
So, first of all, can you hear me and see me?
Yes.
I'm going to try to share my presentation first. That's the first step. I hope it goes as it should. So, can you see my presentation?
We can see, yes.
Okay. So, can we start?
We can see, okay.
So you can see my presentation, right?
Katia, tu vedi la presentazione?
Now, I see a communication email. You are invited to present at free.
We see your
webinar.
screen, but not the presentation.
Yeah. No, okay. I'm going to try it. For some reason, it's not working. Let me just... Can you see?
We see your screen now.
What about now?
We see nothing.
Not yet.
It's white, a white screen.
I'm going to try it another way. Let me see. Oh, okay. Do you see it now?
Yes.
Okay. So, good afternoon, everyone. I would like first to thank the organizers of this webinar. Our subject is neurologic and psychiatric features of MPS 3. I'm going to tell you a little bit about some biologic and genetic aspects of MPS 3 that perhaps you already know. This is a genetic disorder, MPS 3, Sanfilippo disease. It is a genetic autosomal recessive disorder. This means that one child is affected when one copy of maternal gene and another copy from father come with an abnormality, are non-functional. This will happen 25% of time, while 50% of offsprings of this couple will be carriers, and 25% will inherit the normal copy from father and mother. So this is the genetic pattern of transmission of MPS III. Moreover, MPS III has 4 subtypes, that is, has 4 genes. These genes code for 4 enzymes, and those enzymes are involved in the degradation of large molecules called glycosaminoglycans. In the case of MPS III, the glycosaminoglycan is heparan sulfate. Then the absence of this enzyme will not degrade heparan sulfate. It will accumulate in several organs, and so during lifetime there will be dysfunction of the central nervous system, bone, heart, respiratory system, gastrointestinal tract, liver, and this goes along with peculiar physical features of MPS III. Early in life, in infancy, the physical features of MPS III are subtle, so diagnosis is quite difficult at this time, because those characteristics like hirsutism, thick hair, thick eyebrows, prominent lips and ears, gingival hypertrophy are not very apparent. So usually these children have early in life other diagnoses like developmental delay, hyperactivity, and even autism. These are usually the initial diagnostic labels for children with MPS III. Of course, if someone, the physician, is somewhat familiar with this clinical picture, he may consider the diagnosis of MPS III and then ask for urine test for glycosaminoglycans. This test is usually positive, and when it is elevated, we can go on to the genetic test. Usually by whole exome sequencing or a panel of genes, of the 4 genes that are responsible for MPS III. So by doing this, we arrive at the diagnosis of Sanfilippo disease. Sometimes the genetic tests are not obvious in their results. They find what is called variants of unknown significance. So we must do enzyme size just to make sure that those variants are indeed abnormal. So the usual story, the usual picture is a child who is found to be retarded in development. This is variable, the age at which this happens, but usually it is during the 2nd year of life. The developmental delay will become progressively more pronounced. However, the child is still making progress until late school age or adolescence, but her retardation is becoming more and more pronounced. On the other hand, between ages 3 and 5, behavior problems, severe behavior problems appear. Usually, temper tantrums, intolerance to frustration, aggressive and destructive behavior. By this time, physical characteristics of MPS III usually become more identifiable. By adolescence or slightly earlier, regression takes place. Language is reduced and eventually lost, and psychiatric problems increase, mainly destructive and aggressive behaviors that are episodic but become increasingly more frequent and last for longer. There are also sleep disturbances. They are a major problem. Those go from waking during the night to total insomnia for a few days to total reversal of the sleep-wake rhythm. That is, the child is awake during the night and asleep or trying to sleep during the day. These behavior problems and the sleep disturbance are the most difficult to manage because for many reasons, the child is non-verbal and gets easily frustrated. The child may be in pain from one of multiple causes, like chronic otitis media, headache, sometimes hydrocephalus, abdominal pain, because these children often have diarrhea from time to time, also from bone and joint pain related to, I'm sorry, hip dysplasia. So the child is agitated, frustrated, cannot speak, cannot explain what's going on. He may be in pain. It is very difficult to understand the cause of these episodes of disturbed behavior and disturbed sleep. Epilepsy may manifest usually late in the course. Rarely, some patients will have hydrocephalus. Hydrocephalus means that a liquid that is inside the brain and inside the cranium must circulate but cannot because infiltration of the meninges by glycosaminoglycans will block circulation. So this cerebrospinal fluid will accumulate and this will need surgery. Also, some children with MPS 3 have a straight and narrow spinal canal, and this may lead to compression of nerve roots. This will cause some degree of paralysis and may compromise walking. This walking disability, may also be compounded by hip dysplasia and hip pain. With time, in early adult life, behavior problems usually attenuate, especially hyperactivity and aggressiveness. And also, mobility may become restricted, not only due to CNS degeneration, but also to joint and bone disease. Epilepsy, on the other hand, is not usually difficult to control with usual anti-seizure medications. So, what kind of interventions could we have? There are non-urgent and non-emergent interventions like physiotherapy, occupational therapy, speech therapy, educational measures, alternative communication, programs for the education of autistic children may be useful. Hearing must be assessed regularly. But the most difficult problems are associated with behavior and insomnia. There is some literature on MPS 3 that states that behavior problems are usually refractory to psychotherapy. But we may admit that behavior analysis may at least try to detect which events may be triggering a disrupted behavior. Usually, we must use tranquilizers, usually antipsychotics, usually atypical antipsychotics like risperidone, quetiapine, or aripiprazole. And often we use more than one, but the benefit of this polytherapy is unproved and it may be marginal. Also, side effects from antipsychotics are rare, but they may be frightening. They are more common with typical rather than with atypical antipsychotics, but some side effects may be frightening, like dystonic reactions, akathisia, acute Parkinsonism, and the malignant neuroleptic syndrome. Just to say a few words about this, akathisia is an uncommon side effect of antipsychotics, but it could be viewed as a paradoxical reaction to a tranquilizer. When we give, sometimes, fortunately, this occurs rarely, tranquilizers to children and to old people, we can have the opposite of what we were looking for. That is agitation, extreme anxiety. This is called akathisia. Also, because of the severe problem with sleep, melatonin could be used, usually in very high doses, trying to reverse or at least attenuate those problems, insomnia and reversal of the sleep-wake rhythm. More severe cases may require hypnotic sedatives. It is always appropriate trying to determine if chronic pain may be contributing to those episodes of behavioral disturbance. And finally, if the patient has hydrocephalus and underwent previously surgery, there should be close surveillance for signs of shunt malfunction like vomiting and lethargy. And now I'm available for questions and for discussing this issue, these issues.
Okay. Thank you very much, Professor. Are there any questions from the audience? Okay. I have a few questions. First of all, the use of the medications such as antipsychotic, melatonin, is it something that should be used constantly on this child or when it is needed, sometimes when it is needed?
Yes, I think it varies from one person to another. Some children will have severe and long-lasting sleep problems, and those will need perhaps very systematic, daily, and for prolonged periods, hypnotic sedatives, and along with melatonin, and others will have episodic sleep problems. So it varies from one case to another.
Okay. And another question which links your presentation to the one we had in the last webinar about pain management. You said that it might be that some neurological manifestation may be due to chronic pain, maybe because it causes frustration. So can you comment on how to, if it's possible, to recognize if a manifestation, a neurological manifestation, comes from chronic pain or it is only linked to, you know,
Yes,
the
yes,
neuronal problems.
Yes, I think it's not easy, and many times it's unsuccessful. But we should always look for problems like ear infection, problems like hip pain, problems like recurrent diarrhea, because we could have another strategy that is trying to solve that problem, and that will secondarily improve behavior. But I must confess that many times our search is unsuccessful. But it should always be in our minds that chronic pain, or at least pain, may be behind these problems and should be actively looked for. Chronic pain is a special matter, a special issue, because if someone has chronic pain, after a while, that person will have an emotional disorder that is unavoidable. So we should look for both problems and try to solve both problems.
Okay, thank you very much, Professor. Are there any other questions?
I have a question, sorry. You wrote something about hydrocephalus, and so you wrote about signs of, you know, vomiting and lethargy, but is hydrocephalus in our kids, in Sanfilippo kids, something that is not constant, meaning, I mean, the brain pressure, is it something that can change because of weather or, you know, other external factors that we cannot it's not that easy to notice, you know, if there's some hydrocephalus going on. I don't know if I'm clear enough.
Yes,
Okay.
yes. That's an important question, I think, because hydrocephalus is exceptional in MPS 3, but it certainly occurs. Usually, in a cooperative child, there are a few signs that can lead to suspecting hydrocephalus, but if the child is pretty much uncooperative, it's very difficult to look for those signs, like a detailed neurological examination. It's often impossible to do this in a child with MPS 3. So we should have a high index of suspicion, things like disturbed behavior, irritability, perhaps headache. If the child speaks, is able to speak, and is able to describe, but many children will not be able to describe, to report headache. So we must look at irritability, vomiting, usually upon awakening. Vomiting upon awakening could be a sign of hydrocephalus. So the best strategy is suspecting and demanding for a CT scan. Sometimes we might be overreacting to those symptoms, but it's better like this, because otherwise we could miss hydrocephalus that is going on for a while, we are not detecting it. So if the child appears to be in pain, and if pain could be headache, and especially if there is vomiting upon awakening, this could be hydrocephalus. So we should go on to a CT scan.
Okay. Thank you very much, Professor. Thank you for being here today. I think we can move on since we are very late. So if you could stop the sharing of your screen, Professor, please.
Yes.
Okay, Professor Lagler, if you're ready.
I am ready, but we agreed that Simon does the first step and starts with the anesthesia topic, so that I can then later on round up and give a broader view on the topic of patient safety.
Okay.
Hear me? I will try to share the screen. Okay, can you see the screen?
Yes.
Yes, it works.
Okay, hello to everyone. I'm Simon Moser, and I'd like to talk to you about a project that we did about anesthesia in patients with mucopolysaccharidosis. It was a study that was partly funded also from Sanfilippo Fighters and MPS Europe. And it was a cooperation between the UCSF Benders Children's Hospital in Oakland, as well as the Paracelsus Medical University in Salzburg. So we looked at the risk of adverse events in patients with MPS. And looking at the papers, we can see that these patients have quite a high risk for perioperative adverse events. And depending on the paper you look at, it's between 9 and 34%. Now, luckily for patients with MPS 3, the average rate of adverse events is lower than the average rate looking on all the MPS patients, but still it is higher than the average population. And for example, a paper from Dorman described it at about 9%, which is still very high. So concluding, we can say MPS patients have a high risk for perioperative adverse events, and at the same time also a high need for surgeries. Now, we do know some of the risk factors that contribute to the high risk of these adverse events. It's from swelling of the tongue to swelling of the oral cavity, neck instability, to problems with the heart and with the lung. But what we do not know is what methods and strategies are associated with low complication rates. In order to answer this question, we performed a retrospective descriptive study at the UCSF Benioff Children's Hospital in Oakland. And we looked at all the anesthesia protocols where patients with MPS had a general anesthesia, and looked at what type of MPS did the patient have, what procedure was performed, what techniques, anesthetic techniques were used, and did there arise any intra or post-operative complications. We then compared our study with the study of Dorman and his colleagues from 2020. In our study, we included 83 patients, 660 general anesthetics were conducted, and 840 procedures were done within these anesthetics. And out of the 660 general anesthetics, we had a complication rate of about 7 complications, which is a complication rate of 1%. Now, we compared our rate to the complication rate of Dorman and his colleagues, where we found quite a big difference from 1 versus 25%. And obviously, we wanted to know what could be potential causative factors for this big difference. We found two main differences to answer this question. One difference is the method of intubation. Well, we at UCSF, we try to avoid the direct laryngoscopy, since we are convinced that direct laryngoscopy has the risk of causing trauma to the airway causing the trauma causing swelling, and the swelling making the airway even more like swollen and even harder to intubate. And for that, we always try to use as first-line device the fiber optic intubation device. Actually, here you can see that in about over 80%, we did use the fiber optic intubation device, and in only about 10%, we used the direct laryngoscopy, while Dorman and his colleagues, on the other hand, used both methods on about 40%. And the second big difference that we found is the choice of airway device. We at UCSF managed over 75% of the cases with a laryngeal mask airway. Dorman, on the other hand, chose to intubate over 60% of the cases. So, what learnings can we derive from this data? First of all, many procedures, in our case 77%, could be conducted safely with a laryngeal mask airway. But still, it is mandatory to always have a backup plan and have indirect intubation devices like the fiber optic bronchoscope nearby. And second is that the fiber optic intubation, in our case, was associated with an extremely low complication rate. So concluding, we can say MPS has a high risk of anesthesia-related complications, but low complication rates are possible. Now, some factors that contribute to a low complication rate are known. One, for example, is that the anesthetist performing the anesthetic should be experienced with the disease MPS, since this disease has some very unique features, and in order to achieve that experience, a certain level of centralization in order to have a high caseload is needed. Furthermore, indirect intubation devices like the fiber optic bronchoscope should be used as first-line device for intubating these patients. Still, prospective studies and evidence-based guidelines are strongly needed in order to further walk this path towards a better patient safety. And speaking of patient safety, at this point, I would like to give the word to Dr. Lagler.
Okay, so Simon, I think we go right away, and then we take your questions in a package, if this is acceptable for you.
Yes.
And Simon, I think you have to de-share. Yes, that's good.
I think I did.
Yeah, very good. And I will share my presentation. So we shouldn't start with the summary, but with the beginning. And I would like to thank the organizers and firstly ask, what is the plan? Should I be done in 4 minutes so we keep the time, or can we kind of go beyond the planned end?
Professor, just take your time.
Okay, all clear. So I'm very, very thankful for this invitation, and it's a pleasure for me to do this together with Simon, who as a he's now a colleague at the hospital, but he did his research as a student at one of the most established and well-known MPS centers in the world with Paul Harmatz, and it was a great opportunity to have this cooperation. And in this context of international cooperation, we are setting up and facilitating some initiatives that go to the patient safety, and some of them are quite innovative. And it's my pleasure to share our approach. And as a matter of fact, it's several approaches that aim for improved patient safety in MPS patients, to share this with you. And this is going to be an overall MPS aspect, but you are certainly invited to later on ask if there is any specific aspects in Sanfilippo. As Simon already said, the anesthesia risk is somewhat a little lower in Sanfilippo, fortunately, as compared to other MPS forms. And the same is true for other emergency situations, but still there is some risk, and that should be known to you, and you should be aware of innovative strategies to handle this. This is my conflict of interest disclosure. I do not have conflicts with regard to these presentations. And Simon already mentioned that there is special needs and also threats of MPS patients when it comes to anesthesia. And that is a fact that comes from the multi-organ involvement of MPS diseases. In Sanfilippo, of course, there is a very strong CNS involvement, whereas the other aspects of skeletal involvement and other organs are a little in the background, but still they are there. Orthopedic problems, for example, and so on and so on. And this slide was already shown by Simon. It was published by a good friend and very experienced anesthetist in the MPS field, Rob Walker, who manages a lot of anesthesia procedures in MPS patients in Manchester, UK. And these risk factors that Simon already mentioned that come from the narrow airways and for the alterated airways, from the cardiac involvement, respiratory involvement that is possible, they also affect emergencies that can occur outside of anesthesia, for example, in respiratory infection situations or in very progressed Sanfilippo patients, for example, aspiration and aspiration of pneumonia and respiratory infections caused by aspiration are a big topic where, and for example, aspiration of bolus, of globus, of larger pieces of meat, for example, can also be situations that can occur in Sanfilippo patients and other MPS patients with a substantial probability. And therefore, it's important that everybody that manages these patients is prepared for that. And this is why patient safety was a very important concern, not only for me, but also a concern of other very, very experienced MPS experts over the world. And we did a survey together and built a research and working group on patient safety with these colleagues from abroad. And as part of this project, I asked those colleagues what is the most impactful emergency situation, or what is of most critical importance for MPS patients as a group. That's not only Sanfilippo, that is MPS as a group. And as you can appreciate here, anesthesia complications are critically important, as all of the experts agreed. Followed by respiratory insufficiency or respiratory emergencies, spinal cord injuries, cardiac emergencies, and in patients that receive enzyme replacement therapy, infusion reactions can also be important for those patients. So there is a number of emergency situations that are considered important, very important, or even critically important by very well-known and very experienced MPS experts. And one other challenge that is not really an emergency, but is a challenge to the clinical management, is that it's not done with a metabolic specialist or a clinical geneticist that knows very well about MPS. To provide a proper MPS management, you need really a very, very large interdisciplinary, interprofessional group of experts. And this comes with a lot of communication challenges, and that has to be addressed by patient safety standards as well. So let me start with one initiative that we started almost 10 years ago, and this is that we use the methods of medical simulation that is also used for other subjects, but we use it for preparing and making aware clinical teams and parents, preparing them for emergency situations and other critical situations that could occur in MPS patients. And I will not go too much into details which specific emergencies can happen. I've shown you the 5 groups, the large groups of emergencies that are relevant to MPS patients. And we prepare clinical teams on that using such a robot, a dummy, you could also say. It's a highly functional robot that can speak and has a lot of body functions, and that figures a MPS patient in this scenario. This, by the way, is Rob Walker, the author of the paper. This is Christina Lampe, that most of you will know. She's a well-known MPS expert, and that's Stefan Gatterer, part of my simulation team. And we do an MPS anesthesia complication scenario on an MPS symposium. And this is what this medical simulation looks like, for example. And this was so successful that I was actually approached by Michaela Weigel, and some of you will know her. She's our Austrian MPS patient organization president. She's very, very enthusiastic about medical simulation. And she approached me and said, Florian, can you not do something for our parents? They are so afraid of emergency situations that may occur in their own child at home. So what we started about 6 years ago with parents was trainings at the patient organization meetings. And this is a scenario, for example, that is handled by 2 MPS mothers and the patient. So the simulated son of the one mother, he has a respiratory infection. During the night, he develops acute symptoms, and the mothers have to handle it. And now, don't get me wrong, we are not planning to make emergency physicians or paramedics out of our MPS moms and dads. That's not the plan. But as everybody knows that has experienced such a situation already, it's not so easy to even do first aid in these very special situations and to call the ambulance and give the information that the ambulance needs to provide proper management for an MPS patient. So this is trained here on this trainings on patient organization meetings. And this worked out so nicely that we started a study together with our psychologists. And as you can appreciate in this picture, the simulation can be very stressful, but at the end, the people are happy that they made it and that they have learned something about their situations that can occur in their children. And this motivated us to do a study on the effects of these simulation trainings, and 98% of the participants feel that these trainings are helpful. 80% say it's applicable in daily life, and 94% say they feel more secure after this training. There is further effects that I will not mention now in detail. You can read it if you like. But what is very important is that in this, we trained more than 200 family members, parents mainly of those patients, and around 120 participated in this survey. And about 3/4 of all parents had already experienced emergency situations at home. So it's really a common thing, and it's good if parents and families are prepared for that. So that's not all, because medical simulation is not the only method to improve patient safety, and there is even an own research field on patient safety. Of course, mainly this is not about MPS, but we started this expert group, as I said, in order to transfer the medical, patient safety knowledge into the MPS arena. And that's what we've done. And in this project, this is just a part of this expert group. And as you can maybe appreciate, it was the World Symposium in this year. We exchange a lot, and we try to collect all the knowledge, as you can see, from different subjects, ENT, as well as clinical genetics, as well as endocrinology and gastroenterology and anesthesiology. So we have established this expert group, and we are further expanding this expert group to get a really broad and global view on patient safety. And one step was that we asked the experts which patient safety standards are used for MPS patients in their own hospitals. There is a lot of things that are used almost everywhere, like emergency letters or the awareness that it needs a specially skilled anesthesia team to do anesthesia in MPS patients, regular team meetings. And then there is other things like medical simulation that is not so far used at every center. And we are currently finding ways how to expand this in order to make it available for as many as possible MPS families and MPS experts to get the opportunity of medical simulation trainings, but also other tools and strategies like, for example, morbidity and mortality rounds on a regular basis. Because as I said, it's really, really a very challenging aspect to organize and orchestrate this team of multidisciplinary teams that is needed to do a proper management of MPS patients. And now, because the time is limited, I kept it very short. I want to still want to come to another topic as well. When we talk about safety, this is not only safety in emergency situations, but of course it's also safety of drug therapy. And you may say, well, there is not a lot of drug therapy around Sanfilippo at the moment. There is some nice developments, but yet, as you may have appreciated, there is a very interesting initiative when it comes to immunomodulatory drugs. And the largest of this project has been a very, very nice clinical study conducted by Linda Polgren and Julie Isengard from the US. They have had a very nice publication in Nature Medicine on their clinical trial in Sanfilippo patients with an immunomodulatory drug, anakinra, that was developed for totally different diseases, but can be very helpful in MPS. But the downside of their approach is that this clinical trial, phase 1/2 trial, only made the treatment available to something about 25 patients that participated in the trial. And of course, this is very disappointing for a lot of patients. And therefore, we asked the question, why anakinra, which is a drug that is on the market, or other immunomodulatory drugs aren't more often used by MPS experts in off-label use in order to provide this interesting treatment opportunity to their patients. And what we found out in a survey was that a lot of MPS experts said, we are very aware of this possibility, but it's hard to get this negotiated with our ethical committees and most of all with the payers that should pay the drug which is used in off-label use. And therefore, we asked them also if there were a kind of easy-to-use tool that gives a very clear and quantitative insight into risk-benefit ratio on an individual basis. Would you use this, and would you provide immunomodulatory drugs in off-label use to your patients? And more than 95% of the experts said, yes, we would do so. And this motivated us, and this was part of the thesis of Anna Maria Wiesinger, this motivated us to evaluate more than 2,000 papers on immunomodulators and on MPS in order to create a decision analysis framework, a tool that allows individual treatment decisions, a risk-benefit decision on each individual patient, whether or not anakinra or even another immunomodulatory drug may be of more benefit than risk for an individual patient. And we developed this tool and we published it, and we started an international platform for N-of-1 trials. And for now, we have reached out to, or we have included in our international platform 20 MPS centers worldwide and 10 patient organizations that had shown interest in this kind of off-label use and using our tool. And we provide justification and negotiation documents as well as methodological instructions to do this N-of-1 trial. Just one thing is required from the centers that are interested in that. We ask them to give us a feedback on their success in the N-of-1 trial they did, in order to implement this data into our tool and to improve the decision quality that is provided by our decision model. And with that, I want to summarize and close my presentation. I think it is obvious that nowadays, where there is a lot of opportunities, but also a lot of specific threats for MPS patients, Sanfilippo patients and other MPS patients, it's important and critically important to collaborate to secure safe management of MPS patients with regard to emergencies and other aspects, to pool the knowledge on safe clinical systems in multidisciplinary teams, safe use of anesthesia, and safe use of innovative drugs. It's our plan to use these international platforms to provide the best methods for training for nurses, physicians in hospitals and in home therapy, as well to anesthetists and multidisciplinary teams. And of course, not last but not least, we are very happy that we can reach out to many families and provide them with our simulation training. And now I'm happy to take your questions. Thank you very much.
Thank you very much, Professor. Thank you for your talk. And thank you, Simon, as well. It was a wonderful talk. And I must say that when we started designing this project of the webinars focused on how to handle emergency, this is what we were thinking of, to teach parents and physicians how to practically manage this kind of situation. So thank you very much. It's wonderful work, and this is what we had in our mind. So I can start with one quick question to Simon. You talk about, no, my question is, do you think it might be useful or correct from the side of a parent or a caregiver to suggest about how to practice anesthesia in, when it comes to a hospital that has never seen a rare patient?
A lot on the anesthetist, because not always doctors, not always it's easy for doctors to accept advice from parents when they tell them how to do their job. Well, the parents obviously know the child and the disease much better. On the other hand, the anesthetist knows the doing the anesthesia better. Still, I think it is important to emphasize from parts of the parents to the anesthetist that this disease is very unique, and it is important to have some measures and some security measures for this disease that are more than the average patient needs.
Okay.
Now, I would not say you have to use this device in order to intubate this patient, since it depends also a lot on the experience of the anesthetist, if he knows the device, if he doesn't or not. But still, it is important to say to the anesthetist that these patients are unique, they need special safety measures, and that the anesthetist is also aware of this.
Okay, and so do you think information like these we discussed today should be included in some kind of an emergency letter?
I think Florian wants to say something here.
Professor, sorry about. Please.
No. I fully agree with what Simon said. And I just was going to say, Rosanna, this is exactly the way to go. So every patient should have his or her anesthesia risk assessed. This is not something that happens all of a sudden. You can do, and you should do, regular checks of the airways, for example, and other things are needed. And this should go into an anesthesia letter or anesthesia pass. And the parents should have this anesthesia pass or anesthesia letter with them and make the anesthetist aware of the fact that they have this special letter, because it's a special disease that can be associated with some specific risks. And this is for sure much more prone to be successful, rather than as a lay person say that in this publication it says that this and that should be used, this device should be used for our child. In the end, it's the same, because it's the parents that know our children or our child needs special care, and but you only need to bridge or facilitate the access to the information needed. And I also want to highlight one platform that might be interesting for you. And I used to also give this link on the anesthesia letter. It's a platform that is called Orphan Anesthesia. And that is not only for MPS, but also for other rare diseases that have a special aspect about anesthesia. And there is some chapters that give information on anesthesia in MPS.
Okay, thank you very much. This is very useful for us. Thank you. Are there any other questions? No more questions? Okay, so I think we're done. And I would like to thank again our speakers for today. You've been very valuable to us, and I really hope we can have further collaboration in the future.
Happy to do so. Thank you very much for the invitation. Have a great weekend.
Thank you.
Thank you too. Thank you also from my side. Thank you. Have a great weekend.
Thank you.
Thank you.
Bye.
Bye.
Thank you. Bye. Rosanna, ce l'abbiamo fatta. Mari.
Non ce la faccio.
Beh, aspetta che spengo la registrazione. L'ho registrata nel canale generale Sanfilippo Fighters, quindi secondo me anche voi dovreste trovarvela.
Ok.
Però comunque ce l'abbiamo noi.
Ma